Hello everyone, my name is Hailey Choi and I'm an academic and research fellow from Duquesne University Milan School of Pharmacy. I mainly work with the medical team here at Catholic Charities Free Healthcare Center, but I was privileged to conduct a research study at the dental clinic. My research was looking at the medication discrepancies in dental record, so mainly assessing medication reconciliation process in the dental practice. I would like to take a moment to share the results from the research study and also provide some tools to improve the process of medication reconciliation in our dental clinic here at Catholic Charities Free Healthcare Center. So first, I wanted to start off with discussing what medication reconciliation is. Medication reconciliation is a process of collecting an accurate list of all medications that a patient is taking. This should include name, dosage, frequency, and the route of administration. In dental practice, I would just focus on reconciling names of the medications because we are not really assessing the accuracy of the medication therapy itself, but just gathering the information what medications our patient are taking. So this should include both prescriptions and over-the-counter medications, and this needs to be done for every patient at every visit. So then why is medication reconciliation important in dental practice? We know from the previous research that patients presenting for dental care do frequently use medications that have potential to impact oral health. However, it is not known how often the discrepancies in the dental record exist. This is important because discrepancies can lead to drug interactions between local anesthetics and commonly used antihypertensive agents and other medications as well. It can also result in prescribing duplicate therapy when dental providers are not aware of existing therapies that patients are using. The dental visit is a prime opportunity to address and discuss any oral adverse effects that may be caused by medications. So, if dental providers are not aware of patients using these medications, these assessment and educational interventions are not going to be done. These are some examples of more common adverse effects that medication can cause. We know from the previous research that when dental patients are using medications, the most common potential adverse effect is xerostomia, or also known as dry mouth. And you can see the medications that can cause xerostomia listed here. Some other common adverse effects we should be identifying is screening patients for gingival hyperplasia, taste disturbances, and also medications that have potential for abnormal bleeding. Now, I'd like to take a moment to share the study results. The title of the study was Medication Discrepancies in the Dental Record, Implications on Oral Health. So the objectives of the study were to quantify medication discrepancies between the lists collected through the usual care by the dental providers and through the intervention of medication reconciliation conducted by a pharmacist. And we also wanted to see whether these discrepancies have clinical significance or not by looking at potential impact on oral health. So in our methods, we chose our dental-only patients as our study subjects. We have patients they come for both dental and medical care, but because medication reconciliation is already an established service among the medical patients, and we share the same electronic records, so the potential gap exists among those patients only coming to dental care at the clinic. So for the procedural, identification of medication discrepancies was done following the usual care provided by a dental assistant or dental provider, where the medication list was gathered first. And then the pharmacist, so myself, conducted an independent medication review with the patient and compared the medication list gathered with the list on the dental chart in workflow and identified and classified the discrepancies that were found. So for the data analysis, descriptive statistics were used. Started first by quantifying the discrepancies and classifying to one of the four types. We looked at the medications that patients are not on them any longer but still listed in the chart, medications that patients report taking but not listed in the chart, or discrepancies related to either similar drug or class or different dosing scheme. Discrepancies were then further evaluated to determine the potential impact on oral health. So now going over the results, we had a total of 100 patients in our study. There were pretty even breakdown between men and women and the ethnic groups. Majority of our patients were Caucasian. The demographic breakdown was similar to Pittsburgh area. The mean age was 58 years old. We did find that 97% of the patients, so 97 patients in the study, were using medications, and the average number of medications the patients were using were 6. That includes both prescriptions and over-the-counter medications. We also found that 96% of the patients had discrepancies present between what was listed in the dental chart and what were actually done by patients, with average of 6 discrepancies per patient. There were a total 618 discrepancies present. Of those 618 total discrepancies, the most common type of discrepancies was with medications not on chart. This was actually most clinically significant type of discrepancies because this is where the dental providers is not fully aware of what dental patients are using. So certainly the other discrepancies may have clinical implications as well, but we felt that medication not on chart is probably the most important discrepancy. So if we look at this more closely, of those medications that were not documented, 64.6% of them did have potential impact on oral health. Because some medications or medication class has multiple effects on oral health, there were a total of 592 potential effects that were found with undocumented medications. Of the undocumented medications, 17% of them had potential drug interactions with local anesthetics, and 18% had potential effects on bleeding. Here are some of the top lists of medications that were undocumented in the dental charts and also had potential implications on oral health. Vitamins and supplements were most frequently missed in the dental chart, followed by pain medications such as NSAIDs and opioid analgesics. Antihypertensives, antidepressants, and anti-anxiety medications were also frequently missed in the dental chart. When we look more closely at the potential effects of the medication discrepancies, we can see that xerostomia was the most common potential problem, and this is consistent with the previous study that has demonstrated that xerostomia was the most common adverse effect with medication impacting oral health. The other potential adverse effects are listed here as well. So we knew that medications have potential to cause oral health effects, and we also knew that patients presenting for dental care often take these types of medications. So the question in the study was then how often do these discrepancies exist? In our study, we did find that discrepancies occurred at an alarming rate, probably at a greater rate than what they occurred in a primary medical care. So majority of medications that were not documented, they had a potential to cause either oral adverse effects or to impact the dental provider's plan of care. So we believe that this research really highlights the importance of improving the accuracy of medication lists available for dental providers. So the next question now is then how we can improve the process of medication reconciliation at our dental clinic. I'd like to spend the next couple minutes to go over the essential steps of medication reconciliation, how to collect accurate medication lists. So first, it is very important to update patients' drug allergy. This is most essential when you see a new patient at the clinic, but it is good to go over the patient's allergy profile at every visit. Ask about specifics of allergic reactions such as severity and the types of reaction the patient experienced. You can update it under allergies and adverse reaction section as listed here on workflow by clicking the pencil sign right here. Next, to gather medication lists from the patients, it is really important to ask open-ended questions. What medication are you currently taking is the open-ended questions. So this way, the patients have to list the names of medications to answer this question. If you ask a close-ended question like, are you taking any medication? Or is there any changes in your medication list? The answer to these questions will be just either yes or no. So then that does not give us the information we need. When the patients give you the names of medications they are on, you can compare to the medication list on workflow and update the list if there is any discrepancy. So this is what medication list under dental section in workflow looks like. So you can simply actually go place a cursor here and then start typing. Then when you start typing the name of the medication, then it'll kind of give you the drop down of the name, the medication that has a similar name. So you can pick from the drop down list. So I would not again worry about the direction of medication as much because again you don't have to really know and you're not assessing how they're taking it. You're assessing what medication they are taking. So this is the dental medication reconciliation paraphrase. This is something new we are incorporating in workflow's dental section. So this paraphrase will be located in between the allergy section and the medication list. This is developed as a tool to improve the dental medication reconciliation process. The set of these questions in the paraphrase must be reviewed at every patient visit after asking what medications the patients take. These questions are targeting the medications or medication classes that are most frequently used in dental patients and also with potential implications on oral health dental procedures. So I'm gonna go over each question one by one. So the first, you have to click that first question set that I asked patient what medications are you currently taking and compare to what is listed in the medication list of the tab. So this step has to be done before you do the paraphrase. So click on that if you already did that. And next question is, are you taking any pain medication? If they say yes, then you want to ask more specifically what medication they take. Some examples of pain medications are listed here. So opioid analgesics can cause nausea, sedation, and xerostomia, and NSAIDs can cause xerostomia, dry mouth, or it can also increase bleeding time. So I am actually providing the list of all the specific names and then also the oral implications. So that table should be attached to the email that you're finding this video. So next one is about blood pressure medication. So patients do frequently take blood pressure medications and many of them cause oral adverse effects such as taste disturbances and dry mouth. So ACE inhibitors, such as lisinopril, is one of the most common blood pressure medication used, and this can cause angioedema of lips and face, and also can cause xerostomia and taste disturbances. Calcium channel blockers such as amlodipine, verapamil, or the diltiazem can cause gingival hyperplasia, also known as gingival enlargement or overgrowth. So when you identify patients taking these calcium channel blockers, it is really important to assess patients' gums. Some of the non-selective beta blockers, such as cravitolol or propranolol, can actually interact with epinephrine, which is added to dental anesthetics. It is definitely very important to ask the patients about the use of aspirin or any anticoagulants such as warfarin, because these agents increase the risk of bleeding and also prolong bleeding time. Most anti-anxiolytics and antidepressants cause xerostomia, or it is also really important to screen for the use of these medications. Asking about the use of inhalers is very also important, especially because some patients forget to mention about the inhalers when we simply ask about medications. Advair and Flovent are the examples of inhaled corticosteroids, and these are used frequently in patients with asthma and also maybe in COPD patients. And this can cause oral candidiasis, which is fungal infection on the lining of mouth. Albuterol inhaler, also frequently used for patients with asthma or COPD, can also cause xerostomia as well. The use of vitamins and over-the-counter medications can be easily missed if not specifically questioned. Not all vitamins or over-the-counter medications have potential to oral implication, but vitamin D can cause metallic taste and xerostomia, and fish oil can increase bleeding time. Over-the-counter medications can also include pain medications such as Advil or Aleve, or antiplatelets such as low-dose aspirin that were discussed earlier. So it is really important to ask about vitamins and over-the-counter medication use. Lastly, it is important to also ask about any unpleasant symptoms in mouth and give some specific examples such as dry mouth or taste disturbances, as they are most common oral adverse effects from medications. If patients report any of these symptoms, make a note in the space right below this question in the paraphrase. Oh, sorry. Yeah. So this is all I have for this training. Thank you so much for your time listening to this training video, and please feel free to email me if you have any question or comment.